Welcome, dear friends and dear colleagues, to this new webinar from the CSF series, the Cytokine Signaling Forum. In this forum live meeting, that we are going to be speaking about the extramuscular manifestations in spondyloarthritis. You may know this series of meetings that we are being conducted with the help of CSF and also in collaboration with the University of Glasgow, but also other international colleagues and sources where we do try to provide the most recent and most important information on the topics that we are choosing. And indeed, today we have chosen a very interesting topic, I believe, for the field of spondyloarthritis, which is the manifestations that we have that are being rather related to non-directly musculoskeletal symptoms of the patients. And we do know that the family of spondyloarthritis does not only contain the axial spondyloarthritis, those patients with inflammatory back pain, but also or the peripheral spondyloarthritis or even psoriatic arthritis. But we do have a couple of other symptoms that we have to take care of, and this is something that we are going to elaborate on a little bit more and more importantly. Now, together with me, I have very esteemed faculty to help out to give us the most important information on the topic. We have Professor Lian Gensler from San Francisco, and also Professor Pedro Machado from London, UK, who are going to give us those presentations that we are going thereafter to also discuss in the Q&A session at the very end of this meeting. And I'm very much looking forward to this next hour. A couple of housekeeping notes. You will be on mute for the duration of the meeting. If you do have questions to the speakers, please submit them at any time you wish during the presentation or at the end through the Q&A function that you see also in this cartoon or in this screenshot on that slide. If there's any other difficulties, there's a specific different chat box that you may use for. You see that on the right side of this screenshot. So we have two different sources of communication to us or with us. And all the Q&A that will come in, I will, of course, discuss with Professor Gensler and Professor Machado. So we will try to have the most interactive session that we can experience with. We also have discussion among us. And again, this is exactly what this is about in the CSF series, as you may know. Here is the summary of today's day. We will start with the extramuscular or extramusculoskeletal manifestations of spondyloarthritis with Pedro Machado. And thereafter, we will go into the treatment options that we have for these manifestations. And as you see, we have tried to really put together a program that really covers every important aspect of the clinical manifestations and the clinical dealing with these manifestations of spondyloarthritis. And thereafter, we will have a discussion. Now, without giving any further information for the introduction, I'm very happy to introduce Professor Machado, who is connected from London. We've heard there is a lot of issues in London today with strikes, but Pedro, you could not strike. You're live with us. We are very much looking forward to your presentation. Please go on. You're still muted, I see. So
so sorry about that.
I was about to give a presentation for you.
Yeah. No, for some reason the unmute button disappeared.
Right.
Okay, no, it's a real pleasure to be here today to discuss a very important topic in axial spondyloarthritis. And can I have the slides, please?
We see the first slide, Pedro. You should be able to control the screen yourself now.
Yeah, it's not showing up in my screen.
Okay, what do you see? What is there?
I see myself.
Yeah, I don't see it either, Zanwan.
Okay, I do see them.
Okay.
We either you have to find out if you have connected to if you're connected to the right window on your Zoom, Pedro.
Yeah, I'm looking at that. It's not there. Can you see it, Lian, in yours?
No, I'm with you, Pedro.
All right.
I see us.
Yeah,
right.
me too.
Let's do the following. Either you can find it, or what I can do is to, I guess you do have the presentation yourself in the background. You can do this slide. There it goes. So we may have to represent.
I can share my screen if. Okay.
Can you see it now?
Yeah, now it's there now. Yeah.
Let's go.
Okay, thank you. So there are a number of extramusculoskeletal manifestations in axial spondyloarthritis. There are a couple that are less common and usually say that they're not concept related, and we usually mean by that the aortic root involvement or the lung involvement, which are very rare. The ones that we refer to and that are really common in axial SpA is the bowel involvement with inflammatory bowel disease, either Crohn's disease or ulcerative colitis, the involvement of the eye with acute anterior uveitis, and the involvement of the skin with psoriasis. And I guess an important question is, how common are these extramusculoskeletal manifestations in axial spondyloarthritis? And a few years ago, colleagues from the Netherlands looked at the data from the literature and tried to calculate the meta-prevalence of each one of these features, looking at the various cohorts of patients that have been published in the literature. And for the radiographic and the non-radiographic form of the disease, so the radiographic form is what we used to designate as ankylosing spondylitis, and the non-radiographic form when the definite changes cannot be seen on the pelvic X-ray of the SIJs. And the authors could not find significant differences between these two forms in terms of the meta-prevalence of psoriasis or inflammatory bowel disease. So for psoriasis, the prevalence was around 10 to 11% of the patients. For IBD, 4 to 6% of the patients. However, regarding uveitis, there seemed to be higher prevalence in those with radiographic axial SpA versus non-radiographic axial SpA, with 23% versus 16%. And this is probably reflecting the fact that these are all HLA-B27 associated conditions, but that association is probably stronger for uveitis. And as we know, in the group of patients, the subgroup of patients with radiographic axial SpA, the prevalence of HLA-B27 tends to be higher than in those with non-radiographic axial SpA, and this is probably reflecting that fact. And more recently, colleagues from Germany looked at insurance data, and they found figures that are very similar to the ones that I've shown before, with the prevalence of uveitis around 20%, prevalence of psoriasis around 10%, inflammatory bowel disease around 5%. And obviously, this also depends on how you define the presence of extramusculoskeletal manifestations, because you could think about psoriasis, uveitis, or inflammatory bowel disease ever, or at that specific point in time. And what this group of colleagues from Germany did, they tried to evaluate if having additional extramusculoskeletal manifestations, so extramusculoskeletal manifestations in addition to the axial involvement, if that had any impact in terms of disease activity, function, or medication pattern, for example. And what they found is that indeed the presence of IBD or a history of psoriasis were associated with higher levels of disease activity. The presence of psoriasis was also associated with a higher level of functional impairment. And there were some difference in terms of the prescription pattern, with patients with current IBD or current psoriasis receiving more frequently biological or conventional synthetic DMARDs, as well as systemic glucocorticoids, while anterior uveitis was only associated with a higher use of conventional synthetic DMARDs. And it is therefore not surprising that we use these features to aid diagnosis, but also they're also part of classification criteria as expected, and the presence of these features makes it more likely that patients will fulfill a classification criteria, including the ASAS classification criteria for axial SpA. So what does ASAS EULAR guidance say about the presence of extramusculoskeletal in axial manifestations in axial SpA? Well, the updated recommendations for the management of axial spondyloarthritis have been recently published, and I will just highlight two of those recommendations. The first one, the treatment of patients with axial SpA should be individualized according to the current signs and symptoms of the disease, that is axial, peripheral, and extramusculoskeletal manifestations, and the patient's characteristics, including comorbidities and psychosocial factors. So essentially, the presence of these features should be taken into account when treating patients with axial SpA. And in terms of more specific recommendations regarding biologic and target synthetic DMARDs, as you have probably read, these recommendations include TNF inhibitors, IL-17 inhibitors, and JAK inhibitors. So the three classes of drugs, of biologic drugs and target synthetic DMARDs that have been approved now for axial spondyloarthritis, and depending on the pathway that is targeted by the drug, they may be more or less effective in certain extra-articular manifestations, and that's what this recommendation 10 summarizes. If there's a history of recurrent uveitis or active inflammatory bowel disease, preference should be given to a monoclonal antibody against TNF-alpha, and it specifically says here monoclonal antibody because that excludes etanercept, which is a fusion protein against TNF-alpha. And in patients with significant psoriasis, an IL-17 inhibitor may be preferred, and this is because there is some data suggesting that at least in extensive psoriasis, the use of IL-17 inhibitor may be more effective than other drugs. And although it's not mentioned here, I would add that the JAK inhibitors could be an important class of drug to consider in patients with inflammatory bowel disease, especially if these patients have not responded to TNF blockers. But I'm sure Professor Gensler will speak more about this. So coming back to these common extramusculoskeletal manifestations, acute anterior uveitis is the most common one. It can be present in up to 25% of patients with axial spondyloarthritis. The prevalence is increased in males, in those that are HLA-B27 positive and with longer disease duration. It's important to identify acute anterior uveitis early and to treat early. And the typical clinical symptoms are sudden onset of pain, redness, photophobia, tearing, miosis, and reduction in visual acuity. It should be diagnosed by an ophthalmologist. Patients should seek observation by an ophthalmologist when symptoms develop. And prompt treatment should be started. Inflammatory bowel disease, it affects between 5 to 10% of the patients with axial SpA. However, when you think about subclinical gut inflammation, there have been now several studies showing that this is much more prevalent than clinical inflammatory bowel disease and can affect up to 50% of patients with axial SpA. It's also increased with the presence of HLA-B27 and other genetic variants have been also shown to be associated with the disease. And like all the other extra musculoskeletal manifestations, it can occur at any point in time. So before the onset of the back pain, or at an early disease stage or at a later disease stage. Clinical features: diarrhea, abdominal pain, weight loss, blood and mucus in the stool, and in more severe cases, fistula may develop, and this is more typical of Crohn's disease. In ulcerative colitis, you often see bloody diarrhea, rectal bleeding, urgency, and loose stools. In terms of investigations, endoscopy with biopsy is often done. MRI is becoming a tool that is more and more, MRI of the bowel is becoming a tool that is more and more often used in the context of inflammatory bowel disease. And fecal calprotectin can be also very useful screening tool, even in the context of rheumatology consultations. And for those with milder symptoms, there's always this issue of the differential diagnosis between inflammatory bowel disease and irritable bowel syndrome. And finally, psoriasis, which can affect up to 10% of the patients with axial SpA. And it's important to be aware that the phenotype of psoriasis can vary widely. Plaque psoriasis, guttate, inverse, pustular, and erythrodermic, just to name a few. Again, it's really important to look at the nails, and often frequently the nails give us a clue to the diagnosis. So in summary, it's really important to be aware of common extramusculoskeletal manifestations in axial SpA. These are acute anterior uveitis, inflammatory bowel disease, and psoriasis. They can develop at any stage of the disease, so it's important to ask about symptoms at every appointment. And sometimes, for example, psoriasis can be mild and subtle, and also the same, for example, for early inflammatory bowel disease symptoms, which can sometimes be more mild. It's important to consider these manifestations when selecting therapy for our patients. And I think my final message is the importance also of collaborating with specialists for patient assessment and management. And this interaction between rheumatology, ophthalmology, dermatology, and gastroenterology is really important for optimal patient management. Thank you.
Thank you very much, Pedro. I think it was indeed exactly what we needed. This means the entire spectrum of those extramusculoskeletal manifestations. There's certainly more that are, let's say, I wouldn't say less relevant, but less frequently observed. We will discuss them thereafter in the context of the entire treatment of the disease. And this is exactly what we have in front of us now. The first slide by Liane Getzler, who is Professor of Medicine from the US. And Liane, we are very much looking forward to listen to what you have to say about treatment.
Thanks, Xenophon, and great introduction, Pedro, on these EMMs. So it's a pleasure to be here. Why is this not moving? Oh, there we go. Hopefully this works. Okay, just my disclosures, and I will talk a little bit about off-label use of therapies, because sometimes it is hard to manage our manifestation as arthritis in the setting of these extramusculoskeletal manifestations. So I'm going to start with maybe a provocative statement, and Pedro nicely showed the guidelines, which help us to think about how to treat our disease, axial spondyloarthritis, in the setting of the extramusculoskeletal manifestations. And there, we're really treating the phenotype. We're treating a patient that has axial spondyloarthritis and has one of these manifestations. And I'm gonna sort of make the point that maybe as we're thinking about treating these patients, we can be aspirational, not now, but down the road. And instead of treating the way that they appear, we can really think about treating the endotype. So as opposed to the manifestation that may develop over time, can we think at a more molecular level about the manifestation that will develop and really treat that patient, which may be different. And as we learn more and more about these manifestations in our disease, we recognize that perhaps it's not all driven by the same pathophysiology. Maybe it is, but I think we need more studies to really understand these different subtypes in our populations. So the next point I'll make is that actually, as we think about treatment options for these extramusculoskeletal manifestations, we have no direct evidence to really speak to this. So we have, first of all, very few trials examining axial manifestations in subpopulations. And actually an example of a trial that did this was the Maximize trial that looked at axial inflammatory disease, so sacroiliitis, looking at disease activity in the setting of what was defined as axial psoriatic arthritis. So patients that had psoriatic arthritis but had axial disease, and looking at secukinumab's impact on that. But really, we don't have patients with axial spondyloarthritis and IBD looking at the IBD outcomes in those patients. Those outcomes are really derived from integrated analyses because they're often quite rare. In addition, we don't have placebo-controlled trials examining these EMM outcomes in axial spondyloarthritis. An example of a trial that tried to look at uveitis outcomes in axial spondyloarthritis is a CView trial, which examined the impact of certolizumab pegol on anterior uveitis. But this was not a controlled trial. So all of the data that we have when we think about the efficacy on these extramusculoskeletal manifestations comes from the data in uveitis, the data in psoriasis, and the data in inflammatory bowel disease. Most of our data, as I said, are derived from these primary populations, an example being adalimumab's impact on uveitis. The registration trial actually excluded patients with spondyloarthritis. So it looked at patients who had anterior uveitis, but did not include our own patients because they already had an indication for this therapeutic option. And as I said, is when you look at these outcomes, really what you're looking at as an adverse event in clinical trials and integrated analysis. And an example of where this was done was a publication on looking at secukinumab's impact on inflammatory bowel disease, integrating the clinical trials from axial spondyloarthritis, psoriasis, and psoriatic arthritis. And my comments on that are, this did not show an increased event rate for inflammatory bowel disease. But of course, we know that the risk of developing IBD might be different in a patient with axial spondyloarthritis compared to a patient with psoriasis. And so it may not tell us the whole truth about some of these relationships. So I'm going to start with a case, and I'd like you to think about what you would do. This is a real patient that I saw. She's a 43-year-old woman with radiographic axial spondyloarthritis and recurrent anterior uveitis. And initially, she had been given infliximab and had done well, but then for convenience was transitioned to adalimumab. And actually, for many years, she did well on adalimumab, did not have breakthrough flares of anterior uveitis. Her axial spondyloarthritis was controlled, and she was on the standard dosing of every other week. However, she started to have breakthrough flares of a uveitis, really significant. Drops would not fully control it. And the question is, what would you do? Would you add methotrexate to this patient's therapy? Would you add sulfasalazine? Would you increase the adalimumab to weekly dosing? Would you switch back to infliximab? And so the first point I'll make here is I actually don't think there's a single right answer here, partly based on the fact that we don't have a lot of direct evidence. And I think you could justify it based on a shared decision that any of these might be options to consider. I'm interested to hear from my colleagues, actually, Pedro and Xenophon, whether you have a particular direction that you would go, and for people in the audience, think about it and certainly put questions in the chat as you're thinking about this. Maybe I'll ask both of you though. Pedro, I'll ask you to start. Do you have a approach that you would use first in a patient like this?
Yeah, that's a very good question. I think here the shared decision process with the patient is really important. As you said, I think all the possibilities are viable. In fact, increasing the dose of adalimumab is something that I could not do in the UK because I can only use the licensed dosing for axial SpA. So if this was to be done, it would have to be done by the ophthalmologist. So obviously this is a licensed dose for inflammatory bowel disease, but I would not be allowed to do it in the UK. I would probably be inclined to switch back to infliximab because things were controlled with infliximab, if I understood correctly, and if the patient is amenable to that and coming to the daycare unit for a few infusion every 6 weeks, I would probably be more inclined to do that because my expectation is that that would probably be more effective than having methotrexate or sulfasalazine. But again, if the patient, said, no, I don't want to come to the hospital and have infusions, I think any of the first two would be a good option. But if you ask me what would be my first choice, I would probably go for switching back to infliximab.
Thank you for sharing. And I think so much of the shared decision is important to highlight here because it really does come down to that, and also highlights the difference in practice styles at a global level, because I, for good or bad reasons, I'm able to prescribe the IBD dosing and the uveitis dosing for patients. So would be able to use weekly dosing. But, and I think the infliximab, I think the question that comes up sometimes with switching back to infliximab is, will immunogenicity have a role, and will the patient with that break in exposure have developed antibodies against the drug and not respond or develop infusion reactions? But those are sort of theoretical risks that I think are still worth considering. So thank you for sharing. So I just wanted to share, this is the data on the therapies in anterior uveitis included in here. On the left is the FAST trial, which was performed by ophthalmologists. Of course, this is a JAMA study, actually from people from my institution, which was a head-to-head study comparing methotrexate against mycophenolate mofetil to be steroid sparing for uveitis. It was not specific for anterior uveitis, included patients with pan-uveitis, of course, as well, and intermediate uveitis. It was designed as a superiority study and actually did not meet its primary endpoint when you compared methotrexate to mycophenolate at a group level. However, when you looked at some of the subpopulations, methotrexate did better. And so I think that many ophthalmologists now will move towards methotrexate as a steroid-sparing option without thinking about necessarily needing to use a biologic. On the right is the study that was really the registration study that got adalimumab's approval for uveitis, anterior uveitis. And here you can see that adalimumab was better than placebo for treating anterior uveitis, keeping in mind that this study did not include patients with V27-related axial spondyloarthritis and uveitis. So they were excluded from the study, but these are the data that help us think about using biologics and even conventional synthetic DMARDs in patients with uveitis as the manifestation of axial spondyloarthritis. Now, when you think about anterior uveitis in axial spondyloarthritis, these are sort of some of the studies, and I obviously can't be comprehensive in 20 minutes, but on the left is an older study. This was published in 2005, which was a looking at the literature, systematic literature review, where they looked at the trials that had been published at the time, etanercept and infliximab, compared to placebo patients, and showed that flare rates were higher in the placebo-treated patients, even compared to etanercept, and then lower in infliximab. Now, keeping in mind that there could be confounding by indication here in some of these patients that were treated with one drug versus another, so it's a little bit hard to compare them. But at the very least, you can see that monoclonal antibody does the best for patients with axial spondyloarthritis and uveitis flares. On the right is the data from the CView trial. So this was a study that looked at patients with axial spondyloarthritis who had active disease, starting a biologic, certolizumab pegol, and they were enriched for having anterior uveitis, B27 positive. They had to have a flare in the year preceding enrollment, but they were really starting treatment for the arthritis. And this is the type of patient that we would be treating in clinic. And so they looked at patients over then the 48 weeks of follow-up to see whether they had less flares than the year prior to enrollment in the trial. So a couple of points here is on the first figure, you can see that everyone had 1.3 flares in the year preceding, but the requirement was that you had a flare in the year preceding, so that's not surprising. And then you can see that there are fewer flares in the follow-up 48 weeks, and you can see dependent on the number of flares that they had in the preceding year, you can see that the number of flares in the follow-up period go down. So my comments on this are that I don't think we can say that this drug, though it's a monoclonal antibody-based TNF inhibitor, causally prevents uveitis in the follow-up period, because part of the issue is that these are rare events, and is there some regression to the mean, that people would look like this regardless of whether you treated them or not. I think the guidelines actually have us think about the drug options for anterior uveitis or recurrent anterior uveitis at a group level. So we think about monoclonal antibody-based TNF inhibitors being the therapy of choice. But the data is strongest from a placebo-controlled standpoint, really with adalimumab. And this suggests that maybe this has an impact, but keep in mind, this is not placebo-controlled data. So here, let's go on to a patient with psoriasis as a manifestation. And this is a 26-year-old with radiographic axial spondyloarthritis and psoriatic arthritis. True, I promise these are all my real cases. Meeting CASPA criteria, meeting modified New York criteria. She's on a TNF inhibitor and she has controlled musculoskeletal manifestations. So her arthritis is fine, but she has refractory psoriasis. And the question is, would you add methotrexate, change the TNF inhibitor to an IL-17 inhibitor, change the TNF inhibitor to an IL-23 inhibitor, or add topical steroids? And I think, again, these are real cases that we contend with where we struggle because our manifestation, the arthritis or the sacroiliitis, is controlled, but this manifestation is active. So what do you do in this setting? And I think here the answer, for me at least, is a little clearer. We know that patients with axial disease don't respond to IL-23 inhibitors. Whether that's true or not in axial psoriatic arthritis, I think is debatable or sort of still in question a little bit, but we know that IL-23 inhibitors don't work in axial disease. We also know that though methotrexate works in psoriasis, it doesn't work in axial disease. And so adding it feels not that elegant in that you're really just treating the psoriasis, but it wouldn't be totally, you could use methotrexate. I think also in a shared decision, you would take into account the decision for childbearing in a 26-year-old woman. You could use topical steroids, particularly if it's mild psoriasis. I don't think that should be not considered. But we know that compared to TNF inhibitors, the IL-17 inhibitors and the IL-23 inhibitors probably work better for psoriasis. So this is where I think, for me at least, changing to an IL-17 inhibitor from a TNF inhibitor, which would help both. But I'm interested, Xenophon, whether you would do different, and maybe the practice in Germany would not allow you to do this and make you go through a conventional synthetic DMARD first.
Well, I was thinking myself, Lian, what I would do in terms of trying to have the least complicated therapy, but still try to be as effective as possible. And I can already say up front, although this is not your direct question, I was asking myself, what if that refractory psoriasis is just one or two very little spots? Yeah, would I leave it without doing anything even? Yeah, topical steroids is one of the options, obviously, yes. Or is it really a large area of psoriasis, which is not just a cosmetic problem, but it's also the hint that there is systemic inflammation still.
Right.
So this is how I would approach it on the patient. And if there is this kind of systemic inflammatory activity that we obviously cannot control that part of by the TNF blocker, then I would rather switch to, and you mentioned the Maximize trial, would rather switch to an IL-17 inhibitor. Adding methotrexate, I believe, is my lesser favorable option, simply because I do believe that monotherapy with IL-17 inhibitor would be, or hopefully, I would hope that this is more potent. Could then there be IL-17 inhibition and methotrexate in a worst case scenario, or just some prednisolone, oral prednisolone or cortisone in flare situations? That would be indeed what you also mentioned. It would be let's say, patient-tailored treatment. But I would make it dependent on how large the psoriasis area is.
Great. So, and I think that's such a good point, is that thinking about the burden of psoriasis is important. Not just our interpretation of the burden, but how much is the patient bothered by it. Sometimes we underestimate that burden on an individual patient, but a very small area of breakthrough psoriasis would not necessarily be a reason to change systemic therapy. So the study I'm going to show here is the head-to-head trial that was done for ixekizumab compared to adalimumab for psoriatic arthritis. And they used a combined primary endpoint of both a musculoskeletal, an ACR 50, and then a PASI 100. And so here you can see that they meet their primary endpoint, that ixekizumab does better at this combined primary endpoint compared to adalimumab. However, actually one of the points is, so we know that skin is better. However, when you look at the breakdown of the components, actually the ACR 50 is the same for both of these options in a head-to-head trial, and really the combined primary endpoint is being driven by the improvement in skin. And so this is just one example in psoriatic arthritis where IL-17s do better than TNF inhibitors. Certainly there are many head-to-head trials in psoriasis as a primary disease where you see similar results compared to TNF inhibitors. So this is my last case, and this is also a true case. This is a 54-year-old man who, and this was the first part of the case was so compelling that it was a clinical problem solving in New England Journal of Medicine, but he presented with spondylodiscitis and eventually diagnosed with HLA-B27 negative ankylosing spondylitis. So he was treated, not by me, but initially on etanercept for 9 months, and then he presented with fevers, pulmonary nodules, and eventually small bowel perforation, and he was diagnosed with Crohn's disease. So really thinking about the presentation of these patients, atypical when he began, was late onset, after 45, B27 negative, did have spondylodiscitis, but really this was probably IBD to begin with. He was switched to a monoclonal antibody-based TNF inhibitor. Great. So, we know that patients with this manifestation, IBD and axial spondyloarthritis, should at least be considered we shouldn't be using etanercept, we should use a monoclonal antibody to cover the spectrum. So we did that. This is not the end of the case though, keeps going. 18 months later, he presents with worsening back pain and raised inflammatory markers. Is he flaring? L-spine MRI, no bone marrow edema. In fact, he just had some degenerative and structural changes. He gets an MRI to look for his Crohn's disease activity. You heard Pedro talk about MRIs as being a tool that we use for disease activity. And he actually has no gastrointestinal activity, but he has extensive enhancing retroperitoneal soft tissue infiltration that encases the aorta, so looking like aortitis, and into the back. So there's the reason for the back pain. And a biopsy shows a B-cell lymphoma, follicular B-cell lymphoma. So he gets his TNF inhibitor stopped. Now, this is 2019, so give me some credit because this is before oral surveillance data came out. Rituximab is given for the lymphoma. He does well. Celecoxib is used initially for the spondyloarthritis. And then his IBD, they put him on vedolizumab, which, as you know, is a gut-selective integrin inhibitor. That doesn't work. He gets put on ustekinumab, but then his axial disease really does flare. And upadacitinib is added to cover both the spectrum of axial spondyloarthritis. This was off-label before it was even approved. And now, actually today, several years later, he remains on ustekinumab, upadacitinib. This is off-label use, of course. We do not have approval to combine these biologics and JAK inhibitors. And his lymphoma is actually in remission. So, these are scary cases to manage when they have multiple manifestations and comorbidities. And to end, I'm going to sort of show this chart of our diseases, axial spondyloarthritis on the left, and then the manifestations the extramusculoskeletal manifestations, which include for us anterior uveitis, psoriasis, and IBD. And the point here is that there are not that many therapeutic options that do cover the spectrum. As you know, the TNF inhibitors we heard is one MOA that covers the spectrum. And I think we got lucky starting with this as one of the first biologics to be approved because we didn't see these manifestations as problems. But as we've developed more targeted cytokine inhibitors, and therapeutic options, you see that there's less green across the spectrum. And we really do have to think about how to treat the spectrum of this disease when we don't have drugs that cover the spectrum. JAK inhibitors is the one, was newer MOA that really looked like it was going to help across the spectrum. We don't have direct data yet in anterior uveitis. There are case series and trials ongoing that are looking at this. And then to bring up the point of TYK2 inhibitors, which this is sort of the newest molecule on the block. We have no data yet in axial spondyloarthritis. Deucravacitinib is the therapy that's being studied. We know that it works in psoriasis. There's good phase 2 data in psoriatic arthritis, but last year, the deucravacitinib trial failed in ulcerative colitis. So this is TYK2 being a JAK4 inhibitor. It's not, many people will say it's not a JAK inhibitor, but you can see that though we sort of moved a long way from TNF inhibitors then to JAK inhibitors covering the spectrum, now again, we're moving to separation across these EMMs. So I think time will tell as to what our options are in patients with axial spondyloarthritis and any of these EMMs, whether there'll be newer MOAs that really cover it. So in summary, we currently treat the phenotype, and that may not share the same endotype. And I think we can aspire down the road to really think about treating the latter. I think the evidence for EMM management in spondyloarthritis is really derived, and that really being from non-spondyloarthritis trials. And the therapeutic options may still be influenced by these EMMs with variable benefit, though, across the mechanisms of action. And missing from this summary, but I think Pedro said this in his summary, and I will emphasize it so much to say that this is really a multidisciplinary management of these patients. And it's so important that we're having conversations with the gastroenterologist, the dermatologist, and the ophthalmologist in the management of these extramuscular manifestations. So thank you very much for your attention. Look forward to a good discussion.
Okay, thank you very much, Lian. And Pedro, we are now live, all three of us spotted here, and obviously we have a lot to discuss. I may take up one question in Q&A, or one question in the Q&A chat that I saw that was asking whether or not we can add methotrexate to an IL-17 inhibitor. Without having seen that question, I already partly answered that yes, it would be, it is possible, of course, and this obviously has to do with the specific phenotype. Yeah, we do treat the phenotype, Lian, as you mentioned, the specific phenotype of the patient, and if there is any, let's say, additional information or additional symptom that we would like to cover or capture by giving methotrexate, there's no contraindication to that. All right, that is the question that we had on the chat. If there is any other question, please place it on in the Q&A. Q&A window, and we will see and address it. I do have a couple of questions to both of you, and we can start discussing these topics. One question, Pedro, is you've elaborated on the main extramuscular manifestations. However, I mentioned that also in one of them of my words in the introduction to Lian. There's, let's say, there's also many more, right? Yes, we do speak about axial disease. We do speak about or lesser about peripheral disease and psoriatic arthritis, which we know is maybe a more multimorbid situation. But what about, for example, the heart? Okay, it is a muscle, but it's not that muscle that we are speaking about here. What about the heart? What about the lung? What about the kidneys? How would you rate those organs in terms of extramuscular skeletal manifestations that may have to do, and then we will go over to Lian with consideration of what kind of mode of action to use for treatment, let's say, including non-steroidals?
Yeah, so obviously, if we think about the concept of extramusculoskeletal manifestations as a sign or symptom of the underlying condition, lung, heart, kidney involvement it's at least in my experience, it's very rare. The involvement of the apical part of the lungs has been described, aortitis has been described, but I find it extremely rare in our clinical practice. Kidney, to be honest, if there's any type of involvement, is more likely to be due to side effects of combination of comorbidities plus non-steroidal anti-inflammatory drugs, for example. So I think involvement of those type of organs, I usually think more about comorbidities and side effects rather than true manifestations of the underlying disease. But it's important to bear in mind, obviously, and to consider, lung function tests or a high resolution CT scan if we suspect lung involvement, or a MRI of the heart if we suspect myocarditis, or an echocardiogram to assess the heart and the large vessels. So those are, I think it's very important to bear that in mind. But in those scenarios, I think the drugs that we use may have a less important role. And I think we really need to liaise with colleagues from other specialties in order to address those issues.
Well, this indeed is that answer that we would all, let's say, like to share, and I do share that as well. However, Lian, it could be that indeed the patient comes in, and this is not let's say, an issue of treatment priorly, but there is an issue with the heart. Another question to you: would you then skip the NSAIDs, go directly to a biologic just because you think, or let's say even IVD, right, and NSAIDs? Would you then skip the first step?
Right. It's a good question. And for me, I really think about the extramusculoskeletal manifestations as different from comorbidities in that they are linked pathophysiologically compared to the comorbidities, which in the setting of having chronic inflammatory disease or as a complication from drug or disease, but different from a pathophysiologic standpoint. In terms of a patient that has cardiovascular disease, in particular, a known history of CAD as opposed to cardiovascular risk, so controlled hypertension. But yes, then a patient with CAD, I'm not using an NSAID to treat their axial spondyloarthritis. In a patient with IBD, who I'm treating axial spondyloarthritis on, it is not elegant to treat with an NSAID, but I think there it is it's a collaborative decision, depending on the risk of NSAID to the individual patient who might have very mild IBD that doesn't warrant, treatment with systemic therapies. And then for me, I get the blessing from the gastroenterologist. I often tend to use COX selective inhibitors in those patients. But I don't rule out using NSAIDs in a patient that has IBD and axial spondyloarthritis if the gastroenterologist says it's not a problem. And the data suggests, at least from a meta-analysis, that it's ulcerative colitis that may be the disease state that flares more with NSAIDs compared to Crohn's disease. So I think it's not an absolute no for me in that setting.
Right.
I agree with that. I have the same approach.
Thank you. There are some questions in the chat. I will start with Alia Kazaz's question. If a patient has ulcerative colitis and psoriasis, so you do have the IBD issue, you do have the skin issue, but there's no response to infliximab whatsoever. What would then be the next step? Maybe we can start with you, Lian, and then we'll go over to Pedro for the next question.
Yeah, so I think assuming that they're both not responding, then the decision as to what to go next to after TNF inhibitor for the ulcerative colitis has to be driven by the gastroenterologist. I'm not going to choose the therapy for the ulcerative colitis. And then it depends on the burden. We talked about this earlier, the burden of psoriasis. Does it need systemic therapy or can it be managed with topicals? And then I think in this setting on infliximab, I always question, well, is the psoriasis TNF inhibitor induced? Because if it is, then you really need to think about using a different class. You can't go to another TNF inhibitor if the drug is causing the psoriasis. So I really think it depends on what's driving the disease activity. The gastroenterologist needs to weigh in on the ulcerative colitis. What could you use when infliximab is not working for ulcerative colitis and psoriasis? Certainly an IL-23 inhibitor is something that's a newer MOA that would work for both psoriasis and inflammatory bowel disease. So that could be considered, but probably is not the only option.
All right, thank you. Next question comes from my old friend Wayne Shuji, who is also online, and he's asking, please discuss IL-17 inhibitors in SpA and IBD. Is their use contraindicated? Pedro, you mentioned the Azazula recommendations for the treatment and management of spondyloarthritis? What is the decision or the position there?
Yeah, well, we know that there's no evidence of for IL-17 inhibitors in inflammatory bowel disease, and there's a few data to suggest that it might even cause a flare of IBD, and we now have another class of drugs in addition to TNF inhibitors that works in inflammatory bowel disease, which are the JAK inhibitors. So I think I wouldn't say it's an absolute contraindication, because there might be cases, especially with mild inflammatory bowel disease adequately controlled with oral therapy, for example, and where all the other treatments have failed for the axial SpA. I think one could consider IL-17 blockage and monitor the IBD carefully. So I wouldn't say it's an absolute contraindication, but it's certainly a relative contraindication when we have at least two mechanisms of action that can work in both manifestations, axial SpA and inflammatory bowel disease.
Yeah, that's right. Thank you. We can go on to the next question by Roshan Amarasena. Maybe Lian, you can take it up. You may see that I read it out for everyone. Do you test fecal calprotectin routinely in the patient who has symptom of loose stools in your daily practice?
Yeah. So first of all, I love this test. I think you have to know how to interpret it, though. So I think about it as the SED rate for the stool, or CRP for the stool, perhaps. It is very exquisitely sensitive for colitis. It is actually not that sensitive for small bowel inflammation. So be careful if you're thinking this is going to be the the screening test for inflammatory bowel disease. It is also influenced by the use of NSAIDs. So if you have a patient with axial spondyloarthritis and then gastrointestinal manifestations, be careful, because you can see an elevation just from using NSAIDs. And it's supposed to be done first morning. So be careful the way you order and test for it and then interpret it. But I definitely do use it in patients that have any GI symptoms. I don't think it needs to be loose stools, because as you know, the manifestations, especially of Crohn's disease, can be fairly protein. I like it as a triage measure, so that if I have a patient with gastrointestinal manifestations and it's elevated, that patient is going straight for colonoscopy. They don't even go through a consult. At least I can do that here. Whereas if it's normal, then I might send them for a evaluation by the gastroenterologist, because then the differential is broader, and colonoscopy may not be the first thing they do. So I do like it, but I do think it warrants interpretation, and it helps me when it's elevated, getting them straight to colonoscopy.
So you do recommend doing the colonoscopy, obviously, in those patients, just because you want to know what's wrong. You're not just satisfied by the answer of the patient or by the situation of the patient about, well, I do have some symptoms, some cramps. It doesn't have to be even loose stools, but just some cramps and issues in the bowel. Because I've heard that at some point where people say, well, I'm just asking if there is issues with the bowel, and that's already for me something that I have to consider, maybe because of, let's say, even for a colonoscopy, more quiet, more silent IBD issues, right?
Yeah, I mean, I just had a patient with just constipation get diagnosed with ulcerative colitis. So I think you really can't tell based on the symptoms that an individual patient has. But again, so it's neither sensitive nor specific. It's just one more tool we have in our toolbox to think about a patient that has GI symptoms of uncertain significance in the setting of axial spondyloarthritis.
Yes, that's right. And this is also covering the next question about the blood processing in the stool. And indeed, the question is, how much attention do we pay to the symptoms themselves? Well, Pedro, I would like to ask you another question, which might be easier to answer. Yes or no answer is also fine. You're also an expert in myositis, and you're dealing a lot with that. What about patients who do have symptoms that may also, let's say, more generalized? Do you see this kind of symptoms, more generalized symptoms, in patients with spondyloarthritis, as you would see it also in myositis? Of course, there's lab tests to do and obviously find the answer, but what would be your, let's say, message to the patient, to the colleagues who are now online, and say that they have patients who, and now make the connection, have generalized symptoms, musculoskeletal symptoms. It's not SpA like, but there is, let's say, kind of secondary fibromyalgia, not only directly to myositis. So what is your takeaway of how to deal with generalized pain in spondyloarthritis?
Yeah, well, my key message is focus on the physical examination. That's the secret.
Do you mean we have to examine the patient?
Yeah, but to me, it's a secret. That's a proper physical examination is the secret. Through myositis, you have loss of muscle power. True loss of muscle power. It's not only fatigue or stiffness. It's true loss of muscle power. It's very different from more non-specific, generalized chronic pain syndromes or fatigue, even with the generalized sensation of muscle weakening. But in fact, if you do a neurological examination, you see that there's full power. Obviously, a patient with axial spondyloarthritis can have other conditions. So if someone is describing symptoms that could suggest a neuromuscular disease, etc., we should investigate, and that's always a possibility. I remember a couple of patients that developed polymyalgia rheumatica, for example, and or a patient that developed a peripheral neuropathy, CIDP, and so that happens. But again, how do you solve the equation? You ask the right questions, you do the physical examination, and that will hopefully give you the answers.
Although in fact, I came to that question because I was remembering one of our very first patients also being treated with biologics, and we still see these patients who obviously do start with good treatment, whatever that is. At that time, it was biologic. They're doing so well that they really start moving around. They do have the pain, which is muscular pain. You see the CK levels increasing rapidly. You don't know exactly what it is and what you've treated or not. But obviously, this has to do with the fact that the drugs work. And patients have a completely different metabolism of the muscle as well, isn't it?
Yeah, and again, there's always the possibility of the individual to develop the concomitant disease, and that you should always bear that in mind, and then do the appropriate investigations if that is the case. And if the patient develops proximal muscle weakness affecting the shoulder girdle clavicle, and there's an elevated CK, obviously you're going to request myositis specific antibodies, think about an MRI, a potential muscle biopsy. That can always happen.
Last question, Lian. We have one more minute or two. What about things that you do care about? And I know that you do care about them clinically, differences between males and females. Do you believe we should take care of them also in terms of which treatment we should use, or is every treatment fitting to everyone? And I see there is a message about indeed coming to an end. So please let us know what we should either take care of now, or maybe.
Yeah. I think at the end of the day, men or women, males or females, individual patients need to be treated as individual patients. I don't think there's any right answer. That's my take home would be that nothing we say at a group level is going to apply to an individual patient. It has to be a shared decision. It has to be taking into account all of their manifestations, comorbidities, regardless of gender.
Thank you. So this brings us to an end, and this is the summary and close slide. Please, now I do have the control. I see that. I would like to remind you that we've learned a lot about the manifestations of the extramusculoskeletal manifestations and the symptoms. We've listened to the approaches in terms of treatment. We've heard that we have to examine the patient, and obviously that we may have to take care about males and females in the future, but most importantly that we do have treatments that are available which do cover all the aspects of the disease. And I think this is the most important thing to remember. And obviously we can tailor the treatment a little bit about or based on the symptoms that patients bring with them. Now, there is 2 more slides to show you. One about the feedback, which is indeed very important to all of us. So please, before ending, fill the short evaluation form. Hereafter, we would like to thank you very much for your attendance. I enjoyed very much the discussion here with my colleagues. The live stream version of this webinar, I just read it out, is available to view on YouTube of the YouTube channel of the CSF. And one last word is has to do with the future Forum Live webinars. The next one is on the 3rd of May, it's a Wednesday, has to do with the future of JAK inhibitors in dermatology. You see here the times based on your time zone. You may register based on the QR code that you see here. And otherwise, I have to wish you a very nice evening. Thank you, or very nice morning, Lian. Thank you very much, everyone, for attending. And I hope to see everyone soon, either live or in a webinar. Thanks a lot. And thanks to the CSF series for giving us the opportunity to discuss here.
Thanks. Have a great day, everyone.
Thank you. Bye.